4, 3, 2, 1. Sir, we are live now.
Okay, thank you. I welcome you all to the first pre-course webinar of the first surgical workshop on DDH by PGI Chandigarh. I would really like to thank Professor Dhiren Ganjwala for accepting the invitation to host the pre-course webinar actually. And I thank Professor Benjamin Joseph, who is a legend among us from the Pediatric Orthopaedic Society of India, to be an expert for this pre-course webinar. Before proceeding, I would like to remember Professor S.S. Gill, who was the pioneer and stalwart who initiated the Pediatric Orthopedic course and the department in PGI Chandigarh. And he was the light for all of us who took us in the path. So I would like to remember because he passed away last week. And I would like to dedicate this entire course for him. So now I pass on the proceeding to Professor Dr. Dhiren Ganjwala to take it over. Thank you, sir.
Good evening. I think my screen is visible.
Yeah.
Yes.
Yeah, thank you. So warm welcome to the pre-course lecture for the first PGI Surgical Workshop on DDH. The developmental dysplasia of the hip is a very common problem which we see. And how I look at this session is because of the Ponseti technique, we have a very good results with clubfoot. But DDH, the developmental dysplasia of the hip, is still, I consider, as not fully solved problem. And we will see how and what we can do for this. So the topic will be on early detection of DDH. And if you like this presentation and if you want a copy of this presentation, please let me know on either WhatsApp or email. I will be happy to share this presentation. What I expect out of this lecture and the implementation of the message, that after a few years, when Professor Nirmal Raj organized the course on DDH, the topic is not the surgical management, but the topic is changed and it becomes the PGI workshop on non-surgical management of DDH. So that is what I expect, and we will see what are the challenges and how we can overcome them in the subsequent slides. So the points which we are going to discuss in this presentation, there are 4 important points. The first, why early detection of DDH is crucial. That's the first point. The second is the method. How can we detect it early? That's the second point we are going to discuss. The third is, what are the challenges? Yes, we all understand that it is desirable to detect it early, but it's difficult. And what are those difficulties that we will discuss? And the last is how to overcome the challenges which we discussed and what are the options for that. So these are the 4 important points which we will discuss. So first of all, let us understand the importance of normal hip joint in our activity of daily living. Let's see, this is a very common situation in particularly rural India, where a lot of people, a lot of children, they sit on the floor, either in the school, particularly in the earlier years, or at the home for taking the meal. So that's the common position, sitting cross-legged. Similarly, a lot of people in rural India or rural part of the India, they go for this position. The squatting is a very important thing for the daily activity. Yes, playing, running is one of the favorite sports for children. And a lot of people, even when they become adult, they continue to run. Sometimes not as a part of the daily activity, but for the health measures. Playing cricket, we know that the IPL is going on, and because of that, the cricket is popular. And even without that, the cricket is a very popular game. And every part of India, the children, they play cricket. Sometimes as a sports, they go for karate, where when you want to kick, you really need a full abduction of the hip joint. Or doing a stretching or a yoga, that also requires the full abduction of the hip. Or sometimes for a high jump or a long jump, again, we need a good and the full range of motion at the hip joint. Now, cycle is relatively become less and less common because the two-wheelers, particularly the petrol and the diesel or the electrical two-wheelers are becoming very popular. But still, a lot of people, they use cycle. And for cycling, we need a good flexion at the hip joint. So that says that hip, which is stable and have a full and pain-free range of motion, is very important for everyone. Unfortunately, not all children are having a good, full, pain-free range of motion at the hip joint. So that's the sad thing. And our aim is to have a full range of motion for every children. Now, for the second message, I would like to share with you a few case examples. And via these case examples, I will try to give the message that why early detection is important. So the first case, a very simple or a very routine case, a 3-week-old child was examined by a pediatrician, and the pediatrician was examining the hip movement. And in that, he observed that the hip abduction is reduced. He did not actually carry out the ortolani or the Barlow test, but he was carrying out a basic hip examination. And he observed that the hip abduction is reduced. Because it was reduced on one side, he immediately make out that this is something abnormal. He referred the case to a pediatric orthopedic surgeon, that's me. Again, based on the clinical examination, I suspected that this is DDH. We will not go into the detail of clinical examination at this stage. We will see later on. And then I suggested to go for an ultrasonography, and the diagnosis was confirmed. The child was treated with a Paulik harness. And with the Paulik harness treatment, which was given for 6 weeks for full-time use, later on, we saw that there is an improvement on the ultrasonography. So at 6 weeks, we started weaning, and gradually we started reducing the duration of Paulik harness. The Paulik harness was used for 12 weeks. The total duration was 12 weeks. Now, if we look at the important thing, the no anesthesia was given for this treatment. No surgery was required for this treatment, and no hospital admission was required. This was the X-ray of the same child at 8 years. I have all the subsequent X-rays, but I am just showing you the X-ray at 8 years, which shows that it's very difficult for us to find out which hip was affected. And this was the child which I showed you earlier, like he had a full function at the hip, both sitting cross-legged and squatting was possible without any problem. Now, I just would like to ask you, how will you consider this result? You have the clinical result as well as the radiological result. How is the result? That's the first question. You may not answer that in the chat box. Just try to imagine in your mind that what is the result. And the second is, how much is a discomfort to a child and to the family? As a doctor, we usually don't go into the parents or the child's home, but from their description, we can make out that, yes, it was a bit difficult for them to take care of the child. But if we look at the discomfort, it was relatively less. So again, as I said, discomfort to a child, hardly any. Inconvenience to the family, yes, to some extent, yes, but it's looking to the magnitude of treatment, it is limited inconvenience to a family. Let's go to the second case. This is a child who is presented at the age of 4 years. The diagnosis is very evident. There is a dislocated hip on the right side. So now, to make you understand the treatment, the hip which has remained out for so many years, the soft tissues has become tight, the adjacent or the surrounding soft tissues has become tight. And if we want to bring this in, we know that at 4 years, it's not possible to bring it down without surgical treatment. And in surgical treatment, we carry out a soft tissue release, because if we want to bring these down, we know that the soft tissues, I have shown only adductors, but all the surrounding muscles, they become tight as soon as we bring it down. And that leads to a possibility of either avascular necrosis or redislocation after surgery. So to avoid that, we need to take out a chunk of shaft of the femur, and we need to carry out shortening of the femur. And when we carry out this, we need to fix it with a plate. And then if you look at the acetabulum, because the femoral head was not in the acetabulum is also not developed. And we can compare that on the right side, the acetabulum is shallow. It's very important that now if we want a good long-term result, we need to carry out acetabular procedure. And we need to deepen we need to make the roof of the acetabulum adequate so that the hip is stable and the hip develops perfectly well. We put it a graft, and this is what the situation. The child is kept in a plaster for 3 months. This is a post-operative X-rays, which shows that now hip is well reduced and it's in position. Now, surgery for such late presenting cases, I was talking to Dr. Neeraj that it is very common in their part, and I'm sure that everywhere this is very common in India. So this is technically demanding. Usually the surgical time is 3 hours. The child requires plaster for 3 months. And after that, it requires a good rehabilitation. We may not send them for a formal physiotherapy, but at least the restricted range of motion takes a long time to recover. The cost differs. In a private setup, it may be in few lakhs. In a teaching hospital or in a trust hospital, it may be few thousand. But actually, it's a cost to the family. So now try to answer these questions. How much is a discomfort to a child? I'm sure for remaining in a bed with a hip spica and carrying out all the routine activities like eating, passing stool, passing urine is definitely difficult for a child who is 4 years old. How much inconvenient it is to the family? Definitely it is inconvenient to the family. So the next question we need to answer is that even after doing all these, does child become normal after surgery? That's the question we want to discuss and we need to understand. So for that, let's see the case 3. This is a case with a bilateral DDH presenting again at the age of 3 years. The child underwent surgery, one hip. After 6 weeks, the second hip was operated, and the total duration of plaster, child remained in the spica for total 4.5 months. That comes to 14 weeks, child remained in the hip spica. Fortunately, after this, the child had a wonderful range of motion at the hip. And these are the pictures at 14-year follow-up, where we can see that the child is, this is what is the arangetral, where she's performing the dance. And these are the various poses, which shows that the functionality of the hip is really excellent. So these are the various postures. If we look at the X-rays, the function is really good. However, the left hip is really doing well, but the right hip is radiologically not normal. And as a orthopedic surgeon, we know that this hip may not last 6 decades or 7 decades and may lead to early problem in the 4th or the 5th decade. So yes, the result is really excellent. The next question is, does every child get such excellent result? That's the question which parents ask us every time when we suggest that this late presenting DDH requires surgery. The answer is most of the children, yes, they get good function, but let's see the fourth case and that will convey the message. The fourth case, at the age of 2 years, it was detected that child had a bilateral DDH. He underwent the similar surgery described in the previous case. At the age of 4 years, he had a second surgery. So this is the X-ray of the same child at 8 years. I'm not showing you the previous X-rays because the message which I want to convey is starting from here. At 8 years, the orthopedic surgeon observed that the left hip is doing excellently well, but right hip is not good. If you look at the acetabulum on the left, it's really well covering the femoral head, but the right acetabulum is shallow and the hip is subluxate. The child was offered a surgery at this stage for the right hip so that the future problem can be avoided. The child was asymptomatic. So family said that, no, we are happy with the result and we really don't want to go for any surgery now. At 16 years, the child presented with a pain which was even at rest. There was pain on activity. And this was the X-ray. And if you carefully see, there is already cystic changes in the acetabulum, which suggests that the osteoarthritic process has started. At 16, this has become painful. And I'm sure that in next few years, the child will require some sort of surgical intervention, either periacetabular osteotomy or the total hip replacement. That all depends on the patient and the orthopedic surgeon. But this hip has really become a problem. So on one side, on the left, the surgery has given excellent result, but not on the right. So the point is, not all hips become normal after surgery. So learning from these 4 cases, early detected cases, they require a simple treatment and we get a better results. On the other hand, late presenting cases, they need major surgery and not all have good outcome. So basically that conveys the important message. Now coming to the another point, and which is very relevant for our country. So what is the magnitude of problem? Whenever we go to any organization for like taking or reducing the incidence of DDH, we need to tell them that how many children we see. In India, at present, every year, 2.5 crore babies are born. A lot of incidence article which says that the DDH rate is 1 per 1,000 live birth. Even Indian data also confirms that this is what the rate is. So if you look at the USG guided diagnosis, it may be more. But if we just look at the simple investigations like X-ray, the DDH rate is 1 per 1,000. Simple calculation, 2.5 crore birth and 1 per 1,000 means every year 25,000 cases of DDH are taking place in India. This is the magnitude of problem, 25,000 cases. So now the first point is, how can we reduce the incidence of DDH? How can we reduce the number of cases from 25,000 to 20,000? What is the method? To give you some background, before 20 years or when I became orthopedic surgeon, it was called congenital dislocation of the hip. Now it has become developmental dysplasia of the hip. So two terminology has changed. The congenital has become developmental, and the second letter D, initially it was dislocated and now we call it dysplasia. So the reason why this change in the terminology, why it's called developmental, because it was observed that some hips are normal at birth. The neonatologist, the pediatrician, they have examined the child and the hip was normal. But still later on, it was identified that this hip has a problem. So the important thing from that, we changed from congenital to development. There are a lot of other medical legal issues with that, but fine. The important reason is that many hips are normal at birth, but later on they become abnormal. The question why? The reason is incorrect swaddling. And to make you understand the concept why incorrect swaddling, in India, there is a practice that after the birth, for initial few months, the child, someone comes to the child for like giving a bath. After that, the massage is carried out and child is swaddled, means like the cloth is wrapped around the child so that the hips are remaining in extension. Now, the theory is, or the hypothesis is, that in the initial years, the hip capsule and the adjacent or surrounding soft tissues, they are lax because of the maternal hormone. And when these hips are kept in extended position, that leads to the dislocation of the hip. So incorrect swaddling is responsible for few cases of DDH. And so in Japan, they first of all suggested that if you modify the swaddling technique, then definitely it improves the, or it reduces the incidence of DDH. I will show you the video of correct swaddling, and then I will request Professor Benjamin Joseph to tell us about his experience of like his visit to Japan, where they really showed us how they reduce the incidence of DDH. So first of all, let's see the video, and after that we will have a comment from Professor Benjamin Joseph. Sorry, I will play it again so that we see the, sorry for that.
Place the baby with the shoulders on the folded corner. Tuck the left arm down and wrap over the baby's chest and tuck under the right side of the baby. Tuck the right arm down, wrap over the baby's chest and over the arm and tuck under the left side of the baby. It's important to leave room for the legs to move. Bring the bottom corner up, twist and tuck under the baby. Make sure the hips can move up and out.
So that's about the correct swaddling method. And I would pause sharing for a few minutes. Yeah. Yeah, Professor Benjamin Joseph, can you tell us about your experience with the Japanese study which showed that the correct swaddling technique reduces the DDH incidence?
There was a gentleman by the name of Ishida who heard about the work of Robert Salter, who emphasized that swaddling is not a good thing for the hip, infant's hip. And he went and saw the work, and then he came back and tried to spread the message. Fortunately, he had a very powerful man to support him from Kyoto. He was the professor of Kyoto, Professor Takao Yamamuro. So Professor Yamamuro decided, along with Ishida, that they would spread the message very emphatically to the Japanese Orthopaedic Association, Pediatric Orthopaedic Association, and teach them to avoid this habit. So they actually trained nurses and midwives on how to not swaddle the children in the way that they were doing it in the past. And they did it extremely systematically, spread the message to not just the orthopedic surgeon, but to pediatricians, to midwives, to neonatologists, who have you, anybody who comes into the realm of dealing with newborn infants. And they were quite scientific about it, and they looked at the numbers very carefully, and they demonstrated a dramatic decrease in the incidence of dislocated hips. They were not necessarily reducing DDH in the true sense that because they might have been dysplasia, but they were certainly reducing the number of dislocations. And on the basis of that, they were so proud of this achievement that every year they invited two orthopedic surgeons from a different country to come and visit and study what they had done. And Ashok Johari and I had the good fortune of representing India for one of those such visits. It is interesting because Professor Takao Yamamuro was very friendly with Professor Dolakia, K.T. Dolakia, and asked him his opinion as to who should be sent from India. And Professor K.T. Dolakia was kind enough to suggest Ashok Johari and me. But what happened was that they had an age limit, which was far, far lower than what we were. But the Japanese are very hierarchical people. They obey those who are older than them absolutely. And so they decided to obey Professor Dolakia and said, since you're a senior, if you say they should come, they should come. And that's how we went. And we had an excellent time. It was very, very illuminating. It was extremely hospitable. It was a wonderful, wonderful 6 weeks we had traveling around. And we actually met this gentleman in Shida who was quite old and at that time. So yes, they did a wonderful job. So there is a message to us that we can avoid frank dislocation by proper child rearing practices. But I mentioned something that in South India, where it's much hotter, it is not common to swaddle children very much. And they're left free with some very light clothing. So I haven't seen a lot of that actually happening in this part of the world. So I think we were lucky. However, there are certainly missed cases. And that should be avoided. And later you can talk about the screening and I'll give my comments about how and what should be done. Thank you.
Yeah, thank you, sir. And we will come back in the discussion about what we can do it in India. It's really good to know that in southern India, the swaddling is not that popular. But in Gujarat, I can definitely say that swaddling is almost 100% of the children, newborn, they are swaddled. So yes, and I have seen my niece, like when she gave a birth to child, the hospital staff was suggesting the incorrect or the faulty swaddling technique. So yes, we need to do something for that. We will see that later on. So let's continue with the presentation. Sorry, I will start again from the slide where we are. Sorry for that. Okay, I think the slides are visible, right? Okay, so correct swaddling will prevent the hip from becoming unstable. What Professor Benjamin Joseph said that yes, it may prevent the hip going into dislocated position, but dysplasia will remain. So the question is, can this eliminate the DDH completely? The answer is no. The correct swaddling will marginally reduce the incidence of DDH, but it cannot remove the DDH completely or eliminate the DDH completely. Coming to the second D, which has been changed from dislocation to dysplasia. The concept is the dislocation, or sorry, the dysplasia, DDH is a spectrum. We know that on one side of the spectrum is a normal hip. The mildest variety has only acetabular dysplasia, The femoral head is in acetabulum, but the roof of the acetabulum is shallow. Then comes the case where it's subluxatable, means it remains in, but sometimes it goes out. So this is called subluxatable or subluxating. Then comes that it goes out completely and then it got reduced automatically. So this is dislocating or dislocatable. The next in the spectrum is the hip is dislocated, but it can be reduced. So that's reducible dislocation. And the last is irreducible dislocation. So all these are basically the dysplasia thing. So dysplasia includes everything. Now, what happens to these cases of DDH? These cases which we saw, 25,000 cases DDH every year in India, they go into two broad categories. The first category is that they have early detection and treatment. And some cases are not detected and then they are detected late. When child starts walking, the parents observe a limb, or in a bilateral cases, they observe that the child has a increased lordosis, and then they visit to pediatrician or to orthopedic surgeon and the diagnosis is made. So the next question is, what is the ratio of early detected and late detected cases? Frankly speaking, we don't have the reliable data, but I've asked few colleagues about their understanding of the early detected cases versus late detected cases. And it comes to around 30 to 40% of the cases are detected early. And what Professor Nirmal Raj said, that majority of the cases are detected late and they require a surgical treatment. The early detected cases can be managed non-surgically, while the late detected cases require surgical treatment. We wish that what Japan could do it, we also carry out the same thing in India, and 100% of the cases are detected early and treated timely. That's what our wish is. The next question, yes, it's good thing, but how to achieve this? Early detection requires three things by which we can detect early. The first is understanding the risk factor. The second is we examine the child clinically. And the third, we go for imaging. Now, what I'm going to share is the guidelines of India, which was formed last or before 2 years, where the POSI invited Indian Academy of Pediatrics, the Association of Radiologists, the Sonologists, the Neonatologists, and then we form a guideline. And based on that, I'm going to express like how we can do that. So first of all, let us understand the risk factors. We know that the DDH is more common in first child, the female child, the breech delivery, the child where the amniotic fluid is less, oligohydramnios, the child with a torticollis, or having a positional foot deformities like metatarsus adductus. These are the conditions which are been associated with DDH. The next question, does it occur only in children with these conditions, these factors? The answer is no. The next point, can DDH occur even when all these factors are absent? The answer to that is yes, it may occur. So these two important information, I will try to put it in the slide form. If we look at all cases of DDH in this circle, then if we look at the cases with risk factor, there is an overlap, but they don't overlap 100%. So what is important? On one side, we have a DDH without risk factor, and then we have a second group where risk factors are present, but DDH is not there. So detecting DDH by risk factor is not a foolproof method. That's the important message I want to convey. Indian guidelines has reduced the risk factors which we need to consider. So the first is, if there is a family history of DDH, yes, we need to pay more attention. If there is a breech presentation, yes, we need to be careful. And there is a improper swaddling practice in the family, then it's considered as a risk factor. So we have eliminated a lot of risk factors. And the fourth one is, if there is a history of instability on examination in the past, means at the time of birth, that's also considered as a risk factor. But if you look at, we have removed a lot of other factors like torticollis, metatarsus adductus, oligohydramnios from the category. And these are only 4 factors which are considered as risky factors. Coming to the second point, the clinical examinations. The clinical examinations, I am sure that everyone in the audience know about the clinical examination. So there are 2 points which we want to discuss: which test and how frequently. We know that it starts from Ortolani test to Barlow to the hip abduction to Galeazzi, limb length discrepancy, and the abnormal gait. So all these are the factors. And before the walking age group, we need to carry out the first 4 tests as a part of the examination. And for the walking age, the child who is coming to us after 12 months, after the walking age, we need to go for the below 4 test. So that's very clear that which test needs to be carried out. Then comes the next question: how frequently? This is where the major challenge is. The guideline says that we need to carry out examination 9 times. The question is, why do we need to examine 9 times? The reason is, for few examination, child usually is crying, and the clinical examination carried out that point is not reliable. Those who are dealing with children, they know that many times they are crying, and that does not allow us to examine the child properly. So that's the first factor. The clinical examination cannot be carried out properly. The reliability of these tests are not that good. And the third thing is, like, dysplasia can develop later on also. So initially at the time of birth or at the time of 6 weeks, the child may have a normal clinical examination, but it can dislocate later on. So that's another important point. And that's why it has been said that if we want to really avoid the DDH, then we need to carry out examination 9 times. The one point which the terminology is very important to
Can you
understand.
just show me the slide where?
Yeah. Yes. Okay, fine. So coming to the important message or the point, the screening versus surveillance. A lot of people, they consider these 2 terminology similar, but there is a difference. The screening has to be used, that term is used when we have to carry out the test once. Let's say that if we want to check for a thalassemia, we need to carry out the testing once. It's not necessary that we go for thalassemia test every year. If we want to check the blood group, we have to just check it once. We really don't need to go for repeated. The surveillance is a term which is used when we have to be carrying out the test at very frequent interval. Mammography requires surveillance for the breast cancer. Similarly, DDH requires surveillance. Just to make you again clear about this 2 terminology, when we want to sleep, we check that the main door of our home or the residence is closed. That's a screening. That has to be done once. But if there is someone at the border between India and Pakistan, they have checked that everything is okay at 10 p.m. That does not give us a guarantee that at 11 p.m. everything is going to be all right. So there we have to be vigilant constantly And for that, we use the word surveillance. Okay, so coming to the third help, that is imaging. Now, India is a country where we cannot go for a universal imaging. We cannot recommend imaging for every child. We have two options. The first is radiograph. Almost everywhere it is available. And the second one, which is more useful, that is sonography. Everyone knows that the radiograph is not useful before 3.5 months, because when we take an X-ray like this, we are not able to see femoral head, which is lying somewhere over here, but that's not seen on the X-ray. And because of that, we cannot say 100% whether this hip is normal or not. If I ask you for the right side, whether it's normal or not normal, definitely we cannot say with 100%. So radiograph, yes, it's easily available everywhere. It's not reliable for the initial few weeks or months of the life. Sonography is definitely very useful investigations. However, in India, there are limitations that for the sonography of the hip joint, we need a high frequency probe. We cannot use the probe which we use it for the sonography of abdomen. We need a different probe, which may not be available everywhere. Examination of the DDH, usually carried out by a graph method, requires a proper training. And we don't have sonologists everywhere, every nook and corner of India, who are able to carry out the sonography of the hip for the DDH very reliably. And compared to X-ray, it is an expensive investigation. And let's forget about the last 2 points, that it leads to overdiagnosis and sometimes over-treatment. Let's not consider this point, because that's the part and the parcel of when we want to prevent DDH at any cost. That's the price we have to pay. That's overdiagnosis and over-treatment. Coming to a simple message, which imaging technique? According to our guideline, from birth to 1 year, we use sonography for the first 6 months of the life. By that time, at 6 months, usually the femoral head starts ossifying, and then ultrasound cannot be used reliably. And X-ray is used after 14 weeks, that's 3.5 months. Before that, it does not have much reliability, but yes, it's reliable after 14 weeks or 3.5 months. So now let us understand the DDH care pathway in very simple terms. I know that it's a bit difficult to understand at the first glance, but I will try to give you the overview of that. If you are really interested, you can go to the www.posi.in and then you can get this guideline, download it free. According to this guideline, it's divided into 4 age groups. The first is less than 6 weeks. The second group is 6 to 14 weeks. The third group is 14 weeks to 6 months. And then the last one is more than 6 months. So the first question, whenever child present to us, we need to identify in which age group the child lies. And accordingly, we have to follow the path. Let's take a child who is coming to us, is 7-week-old. So according to this, we have to follow the pathway between 6 to 14 weeks. We know that the clinical examination for that is the first 4 tests we have to carry out. Now there are 2 possibilities. It could be a normal or it could be abnormal. So first of all, let's follow the pathway that clinical examination is normal. Then we ask the second question, the clinical examination is normal. What about the risk factor? Again, there is 2 possibilities that risk factor may be present, it may be absent. Let's take the first scenario, the clinical examination is normal, the risk factor are absent. In that case, we just have to continue surveillance. We don't need to go for imaging. However, clinical examination is normal, but the risk factor are present, then we have to go for imaging. Which imaging? Already we discussed before 6 months ultrasound. And if it's not available, then 14 weeks later, we can use X-rays. Our case is at 7 weeks. So we have to go for ultrasound because for that age group, the ultrasound is the test which is recommended. Now, as we discussed that ultrasound test is not available everywhere. So we have taken that point into consideration and we have suggested that what one needs to do. If quality ultrasound is available, in that case, we have to go for the test. Again, we have two possibilities that the test is normal or it may be abnormal. If it's normal, then it's good and we need to continue surveillance. If it is abnormal, in that case, we have to refer the child to orthopedic surgeon or pediatric orthopedic surgeon. However, let's take a second situation, which is common in India, that quality ultrasound is not available. In that case, we have to go for X-rays at earliest, that is at 14 weeks or 3.5 months. On the other end, like this was for when the clinical examination is normal. But if clinical examination is abnormal, in that case, we have to refer to orthopedic surgeon. So coming to that, the summary, when the child should be referred to orthopedic surgeons, two indications, either clinical examination is abnormal or imaging is abnormal. Now, what I described is a long pathways. You have to go normal, abnormal, it's available, absent. So the simple understanding of hip surveillance is like this. We can divide into 4, the risk factor present or absent and the clinical examination. So let's take a situation. The risk factor are absent, clinical examination is normal. We just need to continue surveillance till the age of 18 months. Let's take the second situation. The risk factors are present, but clinical examination is normal. So we go for imaging, and depending on the availability of investigations, we go for ultrasound or X-ray. Then comes the third part. The clinical examination is abnormal. However, risk factors are absent. But because clinical examination is abnormal, the child requires referral to orthopedic surgeon or pediatric orthopedic surgeon. And if risk factors are present and clinical examination is abnormal, then again, child requires referral to orthopedic surgeon. Let's see one case example. A twin child or children. One child was a breech delivery, means the risk factor was present. Clinical examination was normal. But because risk factor was positive, the child was asked to undergo ultrasonography. The ultrasonography shows that this is what the ultrasonography. And if you look at the right is slightly laterally displaced compared to the left. So right is abnormal. The ultrasonography of the right hip is not normal. So now surveillance was continued and X-ray was suggested and it turned out to be normal. So that completes that now this child only requires surveillance till the age of 18 months. What do we expect from this hip surveillance? At present, a children coming to us, a small number they required or they are managed with Paulik harness. Small number of cases they required close reduction, but majority of them requires open reduction, only open reduction with femoral shortening, or all the 3, open reduction, femoral shortening, and acetabular osteo. We want to change this situation, and we expect that with proper hip surveillance, like what Japanese people achieved, most of the patients will be managed with Paulik harness. A small number of cases will require the treatment like close reduction or surgical treatment. That is what we expect from proper hip surveillance. Yes, some people call it like this, that orthopedic surgeon is cutting his own number of cases which require surgery. But fine, let's forget about the financial part first at this stage, and let's take the point into consideration what is good for the patient. And that's why we want to implement this guidelines. Coming to the last few slides, what are the challenges? Yes, it's very difficult, and I would like to enumerate few points which I have realized in the implementation part. We did it really well as far as the guideline was designed, but when it comes to implementation, India is a big country and we have a lot of challenges. So let us understand. The first is DDH is a very unique condition. Why it is unique? Because the condition is not visible to the family from outside. The condition has to be suspected by pediatrician because the child is in contact with neonatologist and pediatrician. So they have to suspect that condition by clinical examination. If it's there, the child is referred to radiologist or sonologist and they confirm the diagnosis. And then the treatment is carried out by orthopedic surgeon. So just if you understand, the person who has diagnosed this condition is not at all benefited in the form of treatment because he is not going to carry out treatment. Vis-a-vis, let us understand clubfoot, how it is different and why we are able to treat it well. First, the diagnosis is very evident. Usually, if prenatal sonography is carried out, the diagnosis is made at that point before birth. But otherwise also, the diagnosis is very evident to the family as soon as the child is taking birth. The diagnosis is evident, you don't need any investigation for that. The confirmation is not required. The straight way we have to go for a treatment and orthopedic surgeons carries out treatment. So that's what the difference between clubfoot and DDH. But more important thing is the challenge is the incidence is 1 in 1,000. Whenever we go to any government agencies to make them, or we try to convince them that we really need to do this, they ask us the question, what is the incidence? And when we say it's 1 in 1,000, automatically their interest in the condition is less. The reason is because there are more burning problem in India for a large number of children. So DDH comes at a very low priority. This condition is not painful, not visible externally, and as I said, risk factor and the clinical examination is again not a foolproof method. They can help, but they are not foolproof. So I consider that finding a DDH is something like finding a needle from the hay. It's that difficult because it's 1 in 1,000, not visible outside. What are the few suggestions how we can overcome the situation? What we can do, we can educate the proper swaddling technique. What Japan did, we can definitely do it. We need to educate pediatricians for repeated surveillance, not screening, surveillance for the DDH. We need to make USG available everywhere. We cannot ask family to go 100 kilometers for diagnosis for the sonography. It has to be made available everywhere. We need to train sonologists for carrying out the hip sonography. But I am really optimistic because if India can eradicate polio by the polio oral vaccination or the oral drops, then definitely DDH can also be eliminated. If we can land a Chandrayaan-3 on the moon, this is definitely less challenging than the Chandrayaan project. If India can do this, then definitely if we join together, definitely we can assure that every child taking birth have a full function, pain-free hip joint. So with these words of optimism, I would like to stop share, and I would request Professor Benjamin Joseph to share his views about why we are not able to reduce the incidence of DDH and implement the guidelines.
Yeah, I was intrigued that you admitted that the implementation is difficult, and I'm not surprised at that at all. First of all, when there are different clinicians involved in trying to achieve the same aim, sometimes you run into problems. So I would be very cautious about the way we interact with our colleagues. Rather than trying to teach them what to do, we take them on board as colleagues who know as much as us or even more than us. But try to say that we've got a common aim, try to win them over, and then try to see if it works. There's nothing to be disheartened about, because I had the good fortune of spending 2 years in New Zealand, which is an advanced country. And the number of missed cases that I saw were phenomenal. So the screening method didn't work there as well, even though ultrasound is available and so on and so forth. So what we need to do is, we need to make sure that every single child is clinically examined. If necessary, either by the pediatrician, the neonatologist, the obstetrician, or the orthopedic surgeon. It is being unrealistic to assume that we as orthopedic surgeons can see a child 9 times and do everything. We can't see all this. There's no way we can do that. But what we need to do is make sure that your colleagues are part of the team. So one of the things we can do is tell them, if we diagnose DDH and we're going to treat them, we want you to help us with the follow-up. So send the children back to them. Once they know that they are not going to lose their patient, they probably be a bit more compliant. So we need to take them on board, try to make them understand how to do these things, have regular opportunities to retry and relearn and retrain how to do the tests. And then we hope that this will improve.
Yeah, what you said is very right, that yes, in a teaching hospital, the orthopedic surgeon or the resident can go to the pediatric OPD or the neonatal OPD or in the ward and can examine every child. That's possible. But for the second, third, fourth, fifth visit, usually that's not possible. So yes, that's what the practical challenge in every part.
You then have to probably train your auxiliary nurse, midwife who's in the primary health center to do some of these things. They may not be perfect, but I don't believe that we cannot train them.
Yeah, naturally we can train them. But yes, it's a big number, the huge number. And if we look at the number of pediatricians in our country, that's again a huge number. More than 30,000 pediatricians.
So why don't you start with one district?
Yes, yeah.
Maybe Chandigarh can do that as a pilot study. Pick up one district or one taluka and try to, over a period of time of 1 year, see that every child that's born is examined, and you have a documentation. You'll have wonderful data, and you can prove to the rest of the country that you can do this.
So wonderful suggestion, sir. It can be done, and we will look forward to do it, sir.
Yeah, good. See, I'm very fortunate. I've retired, so I can sit in an armchair and tell you to do things.
But sir, I'm sure that you must have tried a lot for doing this, because I know that you visited Japan in early, somewhere around 2000 or 2003.
I don't recall which year it was. It was some time ago, yes. No,
yeah, but after that also you must have tried, and what were the challenges which you faced?
Yeah. Point is, I didn't do any field study, which I should have. I wrote about it and said that we do need to do it. But again, for want of priority, I didn't do that. I apologize. And I think that someone should do it. And maybe Nirmal, if you would pioneer something, it would be fantastic.
Definitely try, sir.
Yeah.
Yeah, if there are any questions, we would be happy to answer the questions, because I try to make it simple, but still I'm sure that you must have a lot of confusion or query. So please ask us. See, it's a very rare opportunity for you to ask questions to Professor Benjamin Joseph. It's very difficult to bring him to such meetings. So,
Sir,
you're
is
really-
there a hips? Sir, Kribakaran here from Jaipur, Pondicherry, sir.
yeah.
Is there a hip safe method of swaddling, sir? Is sir believing in the hip safe method of swaddling, which Dr. There was a paper in IJO by Dr.
Ellery Karujis and others. Yeah.
Sandeep Vaidya, sir, and Alaric Aju, sir, regarding hip safe method. Is the senior professor pro or against that hip safe method of swaddling, sir?
Yes, sir. Yeah.
I'm neither pro nor against. I need to see how it works. If it works well, well and good. So we need to have data available which tells us whether the particular method works and if it works better than some other method that's in practice. So anything that you try to implement, you need to have scientific data to prove that it works.
Okay, sir.
Yeah. So,
But sir, already Japan has proved it that it works. So do we need to really prove it, or we just adapt it?
no, we can adapt it, but we need to document. We need to
Yeah,
show.
that's true.
We need to know, when you say that this is the magnitude of the problem, we need to have good, solid data. Like I said, if you take one small area, study it, establish the frequency, then look at intervene, and then see whether we improve. So
Just to answer Kiru Bakran, your question,
Yes,
the
sir.
video which I showed is about the hip safe swaddling.
Okay, sir.
It's from the International Hip Dysplasia Association. It's the video from their website I have taken, and I have made it short so that you understand. I have not shown you the faulty method, because it's very important that the first exposure with the correct method, and the video is about the hip safe swaddling.
Okay, sir. Okay, sir. Okay, sir. Thank you, sir.
Then,
Thank you.
yeah, and then there was one more question. Let me see that. What was that?
So there is a
What is the
question from
difference
Siddharth.
between
Yeah.
early diagnosed DDH and late diagnosed DDH? What is the time limit? Okay, the good question from Siddharth, that what is early diagnosed DDH and the late diagnosed DDH? I don't know the demarcating line, but what I understand is, like, any hip which has been diagnosed before walking age can be treated with, if it's early, by say like 6 weeks or so, by Paulic harness. Later on, the possibility of success of Paulic harness goes down, and we can treat it with close reduction. So that's the early diagnosed DDH. And after walking age, it's a late diagnosed DDH, usually where we need open reduction. Even after 18 months, if initially dysplastic hip becomes normal, do we continue surveillance for hip dysplasia at a later age? Even after 18 months, if initially dysplastic hip becomes normal. So just Akash, I would like to ask you, what do we understand by it becomes normal, with treatment or without treatment?
With treatment, sir, like if we at 6 months we detected a dysplastic hip, we gave Pavlik harness, and the hip at 18 months of follow-up, the X-ray was relatively normal. Do we still continue surveillance, like annual surveillance or something, to detect residual dysplasia at a later age?
Yeah, so basically in that case, we need to have a radiological surveillance just to ensure that the acetabulum is developing properly. So that's the only thing we need to carry out. That yes, every year we need to have one X-rays. The question, how many X-rays, how many years we need to follow up, I don't know, but like we can ask Professor Benjamin Joseph, and he can give us.
My norm has been to take one standing view X-ray once a year till skeletal maturity.
Okay.
My dictum is any congenital anomaly, please follow up to skeletal maturity.
Okay, so that's very clear cut that all hips
Yes.
should be followed up till the maturity.
Yeah.
Or do you reduce, like say, like for 4, 5, 6 X-rays, if everything is going on well, do you
Sure.
reduce the incidence?
You
Sorry,
can
the
make-
taking
If things are going really well, make it once in 2 years.
Yes, exactly, exactly.
you
So
can do
that's
that.
what my practice. So I think, yeah, that's a very important point.
Sure, you can do it.
But the message is like they're required to be followed up till maturity.
And I emphasize, please take a standing X-ray because you'd see a lot of things which you cannot see otherwise. The hips are meant to be stood on, as you showed.
Yes, yeah, that's another important point. Even after 18 months, if any, okay, so that we have taken. Okay. Any other question? Fine. So one point which I told in the beginning, that the aim of this lecture is to not only have knowledge, but to get some stimulation for implementation of the HIP surveillance guideline in India. It's difficult, but as Professor Benjamin Joseph suggested, that we can start with one district. We have with us like Hitesh from Manipal, Dr. Bobby John from Ludhiana. So they can take this challenge and can try this method for a small part, like a one district or one taluka, and then we see. And based on that experience, we can go to one state and then to the whole country. Yeah, Nirmal, over to you.
Yes, sir. Thank you. Thank you for the wonderful lecture, sir. And thank you to Professor Benjamin for the excellent comments and guidance. We are really fortunate to have you both. And also we have in the crowd, Professor Bobby John, Dr. Hitesh, Dr. SP Das, all of us helping us. So thank you, sir, once again. And we hope it goes well, the rest of the course also. Thank you very much. As it
Yeah,
went
and
today.
best of luck for your course also.
Thank you, sir. Thank you, sir.
Thank you. Yeah. Bye-bye.
Thank you
Bye,
very
sir.
much.
Yeah, bye.
Thank you, sir.